Good afternoon, everyone, and welcome to this special Bateman Horn Center webinar. I'm Talia Raschioni, Deputy Executive Director and Director of Medical Education. Today is a milestone moment for us. We are here to share a deeper look into Bateman Horn Center's clinical approach to care and to officially launch a long-awaited resource that has been months, really years in the making, the Clinical Care Guide, Managing ME/CFS, Long COVID, and Infection-Associated Chronic Conditions. This guide represents far more than pages of clinical instruction. It's the product of decades of hands-on care, hundreds of medical lectures, validated and informed research, and thousands of conversations with patients and families navigating life with complex, often invisible illness. At BHC, we know that access to informed care remains a profound challenge. This guide reflects what we've built and what we've learned, offered with the hope that it becomes a path forward, practical, grounded in evidence, and deeply human. So before we dive in, just a few quick housekeeping notes. Today's session is in listen-only mode. We encourage you to use the Q&A function for general questions. Please know that we are not able to answer or respond to personal or patient-specific healthcare questions, and we thank you for your understanding. The Clinical Care Guide will be emailed to everyone who reserved a copy, and it will be made live on our website following this event. The recording of today's presentation will be made available later this month through our YouTube channel and on our website. I want to take a moment to acknowledge the incredible panel of clinicians joining us today. Nurse practitioner Jennifer Bell, featured as our speaker and an essential voice in our clinic. Dr. Melanie Hoppers, Dr. Lucinda Bateman, and our newest addition to the BHC family, nurse practitioner Jennifer Bliss. Dr. Braden Yelman is away on vacation, but sends his best. I also want to express my deepest gratitude to the Open Medicine Foundation, whose ongoing partnership makes our joint medical education efforts possible. And to the communications team, Angela Limford, Michelle Mooney, and Lisa Richardson, for bringing this to life. This would not have been possible without your dedication and passion. And finally, as we acknowledge ME/CFS Awareness Month, we dedicate this session to the individuals and families whose stories shape everything we do. Every insight in this guide, every clinical strategy that we share exists because of you, your strength, your advocacy, and your trust in us. It's now my pleasure to introduce someone who has become an essential voice in our clinical program and in the evolution of our care model here at Bateman Horn Center, Jennifer Bell. Jennifer joined BHC with a rich background in primary care, and in stepping into this space, she brought the kind of steady presence, sharp clinical judgment, and deep compassion for this patient population that they deserve. She has helped expand and refine our long COVID and ME/CFS clinical pathway, and in doing so, she's become a true bridge between primary care and specialty care. In today's talk, Jennifer will share how we approach care for patients with ME/CFS, long COVID, and related conditions, what guides us, what grounds us, and what we hope others will take back to their own practices. While she won't be diving into detailed diagnostics or treatment today, you can explore those further through our Project Echo lectures and, of course, our new Clinical Care Guide. Jennifer, thank you for everything you bring to this work. I will turn the time over to you.
Thank you so much, Talia. Let me just go ahead and share my screen here. Very nice introduction, and it's great to have everybody here. We thank you so much for joining. I'm just going to go ahead and get started. So as you know, we are launching our Clinical Care Guide, and this talk is to sort of give you an idea of how we approach care at BHC. So I'm hoping this will provide you some insight into how the providers at BHC approach care for ME/CFS patients. There is no one particular way to care for each patient, and each person is unique in their presentation and response to treatment. However, there is a strategic approach that we take in assessing and treating all of our patients. Today's, I would like to try to explain that to you. More importantly, we could not do this without you, as Talia already mentioned. Your incredible insight into your illness, perseverance, courage, and patience helps us help you better. Even if you are not a patient at BHC, we learn from you in the ME/CFS community forums and advocacy work. Please keep speaking out as this informs us not only with our direct care, but our research and educational initiatives. We hear you and we value your experience. Before I dive in, I wanted to share some of my background and personal experience with ME/CFS. In 2021, I was hired at VHC as part of a team to develop the Long COVID program. I had practiced as a nurse practitioner in primary care for about 27 years. I had a lot of experience in many areas of healthcare and understood the way our healthcare system works, for better or for worse. I understood it. When my family and I moved to Salt Lake City in 2020, I wanted to practice in a different kind of system, one that truly valued the patient-provider relationship, one that would challenge my knowledge base and make a difference in this world. I found that in VHC. When I was applying for the position at VHC, I didn't really understand ME/CFS. I was aware of it. I believed it was real, but I really didn't know how to diagnose it or treat it. During the first few months of practice, while I was in the very, very steep learning curve, I started to understand that the persistent and sometimes debilitating fatigue and exertional symptoms experienced by both my husband and daughter might be ME/CFS. After extensive evaluation and treatment trials, we now know that indeed they do have ME/CFS, and we as a family, and I as an informed clinician, are learning to reimagine and navigate our future with this illness. While the diagnosis is challenging, at least we know what it is and have tools to move forward. I recognize that far too many people out there do not have the same access to care that my family does. This is why VHC's educational initiative to clinicians, both domestic and international, are so important to every person and family who lives with them. Okay, so we all know that increasing the access to care for people with ME is critical. There are nowhere near enough clinicians out there to meet the needs of all the people who have ME/CFS, not only for initial diagnosis, but for continued care and access to emerging research. More clinicians need to be educated on this illness, how to recognize it, and how to diagnose and treat it. They need to understand the complexity of the comorbid conditions and to have the tools to manage it within an overburdened healthcare system. Part of VHC's response to this challenge has included increasing educational forums for clinicians, infiltrating schools of medicine, nursing with ME/CFS curriculums, and developing our clinical care guide to take the clinician through the process of assessment, diagnosis, and treatments for people with long ME/CFS, long COVID, and other infection-associated chronic conditions. The guide further highlights the importance of patient-centered care and patient advocacy. As I said earlier, I would like to take you through our strategic approach to ME/CFS care. All the while, remember this guide is now available to you and to any clinician who chooses to use it. Okay, so let's just dive right in. As many of you know on this webinar, you know what ME/CFS, and you understand that it varies a lot throughout a person's life. Some people experience ME intermittently with moderate levels of severity, and others experience very severe illness that is completely disabling. An ME/CFS diagnosis is based off the presence and severity of symptoms. In order to meet the diagnostic criteria, the person must meet and have the following symptoms as outlined in the blue box. So they must have impairment of normal function accompanied by fatigue persisting greater than 6 months. They must have post-exertional malaise. They must have unrefreshing sleep. So no matter how much sleep a person with ME/CFS gets, they just do not feel refreshed. They must have either cognitive impairment or orthostatic intolerance. These symptoms must be moderate to severe and present greater than 50% of the time. In the other box, there are some additional very common features we see within ME/CFS, but they're not required for the diagnosis. There are a number of comorbid conditions that accompany ME/CFS. These conditions vary in severity and are not always present in all people. This creates what we call a very heterogeneous presentation of ME/CFS. Therefore, in addition to understanding how to diagnose ME/CFS and identify post-exertional malaise, clinicians need to understand what the potential comorbid conditions are and assess for them in each patient. I'm going to walk you through some of the most common comorbid conditions. But we first start by listening to the patient's story and determining whether they might meet the criteria for ME/CFS. This is definitely the first step that we do. We do a very thorough history We pay attention to what their function was before, both physical and cognitive function, and what it is now, so we have an understanding of the impact of the illness. We pay attention to the trajectory of the illness and the severity and frequency of symptoms to really get an understanding if they have PEM. Why is it important to not miss PEM? Managing PEM is the cornerstone of MECF care. If PEM goes undiagnosed and unaddressed, then the patient has a very high chance of having worsening function going forward. As you have all experienced, knowing all you know about post-exertional malaise, how to pace, how to avoid it, and how to get out of a crash, PEM can still be very challenging to manage. Some management of PEM is truly a collaborative effort between you and your healthcare providers. It is our job to teach healthcare providers about this. For some of you who are on this webinar but maybe don't have ME/CFS, what is PEM like? This slide represents all the different symptoms a person can experience with PEM. PEM varies within a person and from one person to the next. Some people will experience all of the symptoms with particularly bad PEM events, and others will only experience a handful. PEM can last for a day, a week, or months. While there are many comorbid conditions associated with ME/CFS and long COVID, PEM is the most devastating and life-changing aspect of this illness. So one of the first comorbid conditions we start with is looking at the autonomic nervous system. I just wanted to give a quick overview. Autonomic nervous system is made up of two branches. The parasympathetic nervous system, which is our rest and digest, it enables us to go to sleep. It enables us to digest our food. It enables us to get into a calm state. The sympathetic nervous system is our fight or flight. It is what enables us to run from the tiger if we need to. So it shunts all the blood to the muscles to function. Our pupils dilate, our heart rate increases, our breathing increases. It's everything we need to be able to do that. One of the things that happens in ME/CFS and long COVID is the sympathetic nervous system takes over. The parasympathetic nervous system is downregulated and the sympathetic nervous system is full on. I liken it to you're in a car, the car's in neutral and your foot's on the gas. You're not going anywhere, but you were just revving at a high speed. That is an exhausting state for the body. We call this dysautonomia. And dysautonomia is often the low-hanging fruit. And what we mean by that is if we assess and treat dysautonomia, we have the potential to resolve a number of different issues. So we assess by listening for the history that might suggest dysautonomia and orthostatic intolerance. We do 10-minute Nasoline tests, which are standing tests in clinic. We can do questionnaires such as the Orthostatic Intolerance Questionnaire and Compass 31 questionnaire. This all helps us understand what type of dysautonomia and level of orthostatic intolerance you have within the dysautonomia. We assess for cognitive functioning because we know that decreased cerebral perfusion secondary to the orthostatic intolerance can greatly affect cognitive function. We utilize devices such as Oura rings and Fitbits and stuff like that to evaluate heart rate variability, resting heart rate, and sleep cycles, particularly deep sleep. Deep sleep is incredibly important for our bodies to heal. It's the time when our cells repair, and many people who have dysautonomia never get into a deep sleep. So their bodies are never able to fully repair. So we work very hard to try to help people gain deep sleep. We do this by treating the vascular system. We increase fluid and sodium into the vascular system by having patients consume large amounts of water and sodium. We also use medications to help compress the blood vessels, and also we use compression clothing to try to push that blood back up because it gets cooled down in the lower extremities and in the abdomen. We manage heart rate and blood pressure to try to maintain normal heart rate and blood pressure. We try to improve blood flow back to the heart and also to the brain. As I said before, we really work to try to improve sleep by calming dysautonomia down, but we also will address neuroinflammation, pain, and mast cell activation syndrome for managing sleep. And finally, we will often use vagal nerve stimulation techniques such as meditation, resonant breathing, neuroplasticity programs. These can be very helpful to help stimulate the parasympathetic nervous system, but these modalities often work better once the patient has achieved some stability. So the next comorbid condition that we look at is mast cell activation syndrome. Mast cell activation syndrome is a very complex immune reaction by the body where the front line of our immune system, the mast cells, are over responsive to the outside world. Mast cells are present in all areas of our body that are exposed to the outside world, such as eyes, nose, mouth, skin, GI system. We also have mast cells lining our vascular system. When these mast cells start overreacting, it can cause a multi-system reaction. Unfortunately, we now understand that mast cell activation syndrome plays a significant role in infection-associated chronic conditions such as ME/CFS, long COVID. So it's very important that we assess and treat for this in our patients. We do this by listening again to the symptoms, and we screen our patients frequently for mast cell activation syndrome. The symptom screen is very, very effective in identifying if it's present. Laboratory evaluation is also available, but it's fairly low sensitivity if somebody is not in a major mast cell flare. We have a low threshold for suspicion of mast cell. We reassess frequently because we know it can emerge after particular PEM events. And we listen for mast cell symptoms as part of your PEM symptoms, which gives us a clue that maybe mast cell could become a bigger player if we can't get things under control. We treat by educating our patients to avoid triggers. We try empiric therapy, which can often be diagnostic, and in some of the mast cell regimen medications or over-the-counter medications, empiric therapy is often quite safe. We start one therapy at a time. We consider the use of compounded medications so as to reduce the number of additives in medications. We try to establish strategies for mast cell flares, which happen with post-exertional malaise. And we involve allergists and immunologists as needed. The third comorbid condition that we evaluate for is pain, and pain is a huge one. I'm not going to talk about all the potential type of pain that's out there. I'm going to focus on the ones that we see primarily in ME/CFS. The statement at the top here is important. Pain in infection-associated chronic conditions such as ME/CFS, long COVID, fibromyalgia, and hypermobility syndromes arise from a complex interplay of neuroinflammation, autonomic dysfunction like dysautonomia that I just discussed, impaired pain modulation where the body receives pain signals, but then the brain doesn't know quite what to do with these pain signals, so it becomes impaired. And musculoskeletal instability, where our skeletal system is no longer being supported as well as it needs to be by our connective tissue. So the pain presentations in ME/CFS are often associated with these four issues here. Some of the types of pain we see in ME/CFS are widespread body pain, which is diffuse. It moves around. It's not in one limb all the time. It isn't always there. It usually worsens when post-exertional malaise is more present, when there's been overexertion. It can sometimes be accompanied with nerve pain, burning, tingling, numbness. And when somebody has this, we're thinking fibromyalgia, small fiber polyneuropathy. We see a lot of joint pain, subluxations of joints, dislocations of joints. When we see that in ME/CFS, we are thinking hypermobility, which I'll talk about in a minute. We have headaches, and headaches in some of our patients can be very, very difficult to treat. And the particularly challenging ones are the ones that are more pressure headaches, treatment resistant to most of our headache medications. We think hypermobility and venous congestion syndromes. To assess for pain, we will use a lot of pain assessment tools like the 2016 American College of Rheumatology Fibromyalgia Questionnaire, Tender Points. We can assess for small fiber neuropathy, which is usually a clinical diagnosis, but you can get skin biopsies and do QSART testing for dysautonomia. We assess for hypermobility and connective tissue disorder, and we do imaging and other diagnostics as appropriate for pain presentations. To treat pain, I'm going back to that initial statement of the four types of pathology that can occur in ME/CFS that can enhance pain. So one of the very first things we do is we start focusing on pacing and PEM avoidance. It is key. We try to improve autonomic function, dysautonomia with increasing fluids, compressing the vessels, treating dysautonomia. Sometimes by just doing that, a lot of pain improves. We manage mast cell activation with antihistamines, mast cell stabilizers, which can really help reduce pain. And finally, and not by no means least, we optimize sleep. That deep sleep, that time when our cells restore, is critical to management of pain. We use medications such as low-dose tricyclic antidepressants, melatonin, and dysautonomia treatment to do that. We also address central sensitization. And central sensitization is part of that disordered pain response by the brain. We're really trying to treat the brain's response to pain. So we use low-dose naltrexone, tricyclic antidepressants, SNRI antidepressants, and anti-seizure agents, GABA analogs such as gabapentin and pregabalin. These can be very helpful in managing that central sensitization pain. Of course, we utilize standard pain medicines because we all know that not everybody just has one type of pain presentation. So if we can reduce maybe arthritic pain or other types of pain, that will help reduce the pain signaling in the body. And of course, we use pain management when it's appropriate. And finally, the last comorbid condition I'll talk about is hypermobility and connective tissue disorder. There's one slide on this, and this is a massive topic, so I'm not even going to scratch the surface. I just want to give you a little idea of where it fits in all of this. Over the last many years, we've been aware that hypermobility and connective tissue disorders play a role in ME/CFS and long COVID. And we are only becoming increasingly aware of this. It is a highly complex disorder of which we don't have all the information we need. There's no easy pathway through this. There's no defined pathway of diagnosis and treatment. So we are still very much on the learning curve. But what we do know is that we know the presentations of hypermobility and connective tissue disorder are usually in musculoskeletal manifestations such as joint pain, subluxations, dislocations, overuse injuries. We also know that autonomic dysfunction and dysautonomia, we know that hypermobility plays a role in that. We know that mast cell activation syndrome is also playing a role in hypermobility and vice versa. We think that mast cell activation syndrome may be part of what causes some of the persistent inflammation that can start to degrade the connective tissue. And then back to those headaches again, those base of skull headaches, those pressure headaches, positional headaches that are worse with post-exertional malaise and unresponsive to usual medications. These all tell us that hypermobility and or connective tissue disorder may be present. We can assess with what we have now is a Bateman score, which assesses for hypermobility, a Brighton criteria used to diagnose hypermobile Ehlers-Danlos syndrome, 5-point questionnaire for joint hypermobility. Genetic testing, there is a role for genetic testing, but it's not critical. But if you are getting surgery, then genetic testing for certain variants is valuable. And it's also important to know there's no genetic marker for hypermobile Ehlers-Danlos syndrome. We also can use imaging such as brain, spinal, venous, and venous imaging is indicated. Right now, what we know to treat, we will do aggressive management of post-exertional malaise, dysautonomia, mast cell activation treatments. We will treat pain. Thankfully, we have physical therapists on board who are invaluable to us in managing hypermobility. First, they can aid in the diagnosis and are very critical for management. We can refer to orthopedics, neurology, vascular, and or neurosurgery is indicated, but we have to really pick and choose who we refer to because not all of these specialists are familiar with hypermobility connective tissue disorders. So that takes me to referrals. So we try not to do this in a bubble. We try not to do this alone. We have to collaborate with specialists a lot. The most important thing we can do is find trusted referral sources for these patients. And we have to be very clear as to why we are referring patients to specialists. We're not necessarily referring them to take care of long COVID or ME/CFS. We're referring for is more specific evaluation, more specific testing, more specific treatments. Common referrals that we use is our physical therapy that I've already mentioned. They are invaluable to our patients, but we are very choosy about who we use because we want physical therapists who understand about post-exertional malaise. Occupational therapy can be immensely helpful for helping people pace, but particularly for our more severely ill patients. Speech therapy can help a lot in cognitive processing and memory. Allergy and immunology for mast cell activation. Neurocognitive specialists for if we're moving towards trying to get disability for the patient. Neurology can be very helpful in evaluating for unusual neurologic findings and may be very helpful in evaluating for increased intracranial pressure, head and neck venous congestion syndromes, and headache management. Pain specialists can be very helpful as well. They can provide alternate pain management regimens and stellate ganglion blocks. Behavioral mental health can be particularly helpful with processing medical and grief trauma, along with challenges associated with chronic illness and chronic pain. and cardiology for more advanced workup and certain prescriptions. So I'm just going to pull back a little bit and talk more about the philosophy of care. First and foremost, clinicians who take care of ME/CFS and long COVID patients need to be strategic and flexible in their approach. A linear fashion with a clear starting point and a clear ending point is not going to work with this illness. We know that ME/CFS waxes and wanes a lot. It's a very dynamic illness in terms of how it can change. It can be affected by many external factors. Patients can go through significant relapse and have periods of feeling much better. So it's very important for us as clinicians to be strategic and flexible in our approach. We also understand the importance of partnership and collaboration with our patients. You teach us so much, you understand so much about your illness that we need to listen and make sure we collaborate with you. Expectations of care is really important. I've had so many patients come to me say they've heard that nothing can be done for their long COVID or ME/CFS. I have seen this written in news articles and repeated in many places. While we may not be able to cure these illnesses, we certainly can do something. We can do something to stabilize it, improve function, possibly enabling someone to be able to work again, to be able to engage with their family and their community. But most importantly, give them some hope. And this isn't false hope. We actually have things that we can do to improve things. We cannot step back and say there's nothing we can do. We must try. It's also important to set realistic goals for yourself as a clinician. You have to understand that you're not going to cure this at this time. We don't have what we need to cure this. We may do in the future, but not right now. So we have to do the best we can to stabilize and improve function. There are medication strategies like starting low dose and going up slowly on doses, using compounded medications to reduce reactions to medications, starting one medication at a time so we know what's causing what. It's also really important for clinicians in an area that's kind of new and unknown to still maintain treatments that are within their comfort zone. But I will also challenge clinicians out there to expand your comfort zone. There are no FDA-approved treatments for long COVID and ME/CFS, but there are many FDA-approved treatments for the comorbidities and a lot of research and case studies to support non-FDA-approved approaches. You as a clinician have a duty to find resources, stay up to date on recent research so that you know how to help your patients best. We can't wait for everything to be FDA approved for new therapies or even old therapies being repurposed. It is a prohibitively long and expensive process, and people are sick now and need our help. We need to be able to do a risk-benefit analysis of therapies that maybe we're not as familiar with. We need to attend continuing education to expand our knowledge and stay current on emerging research utilizing ME/CFS forums, both lived experience and clinician-driven. We need to be able to have frequent visits with our patients. The every 3 to 6 month patient visits isn't going to cut it. Especially when we're first getting to know patients, we need to see them back every 2 to 4 weeks. We need to understand so that we can understand what is happening for this patient and how treatments are working. We also need to assess work accommodation and school accommodation and the potential need for disability. And we need to assess needs for and access to social services, mental health services, and community support. And finally, I want to close with a patient case that I think highlights how we work through comorbid conditions and the importance of identifying ME/CFS and PEM and how to manage it. This person did give me permission to use her case. I have no identifying information in this case. This is a 31-year-old woman who got COVID on November 2020. She has a past medical history of migraines, endometriosis, iron deficiency anemia. She presented at Bateman Horne Center in about a year later in December 2021 with a diagnosis of POTS and was 6 months pregnant. She had already been evaluated by cardiology and neurology and gastroenterology and was being treated for POTS with aggressive water therapy and dietary sodium, some as needed propranolol, compression clothing, and iron supplementation. When I met with her, she met the criteria for ME/CFS with moderate to severe symptoms 50 to 75% of the time. Her orthostatic intolerance was about 75 to 100% of the time. Her NASA lean test was positive. She had significant symptoms of venous pooling, head pressure, headaches, shortness of breath, and increased restlessness. Laboratory evaluation was essentially normal. And basically, for the next 3 months, I focused on aggressive hydration and boosted her sodium supplementation, which did help stabilize her orthostatic intolerance a little bit more. We also spent a lot of time talking about pacing and PEM, particularly in the postpartum phase. And we think she was doing pretty well because she had expanded vascular volume from the pregnancy. She did pretty well after she gave birth for about 2 months, but then she started to experience bone crushing fatigue, dysautonomia, widespread pain, headaches. And these headaches are different than her prior migraines. They were more of a pressure headache. Her Nasoline test was not that different. She was nursing, so we really focused on oral hydration and sodium and compression. Her mast cell screen was now a little more positive, and she also had some positive laboratory tests. Again, she was nursing, so we focused on avoiding triggers such as low inflammatory and histamine diet. And then I didn't see her for 14 months. She was busy being a very busy mom. She already had another child who was a couple of years older, so she was busy. When she returned to BHC, she was having worsening and persistent PEM, brain fog, dysautonomia, unstable blood pressure and heart rate. She came with a diagnosis of mast cell. She had sleep disturbances, widespread body pain, and worsening iron deficiency anemia. Cardiology was managing the anemia and was able to provide some iron infusions, which unfortunately didn't help as much as I had hoped. She had seen a geneticist and had been diagnosed with classical Ehlers-Danlos syndrome. And based on my evaluation of her in the clinic, she was also hypermobile. And then she had a repeated COVID infection in June of 2024. So we focused again on pacing and PEM avoidance. She did pretty well for that first year, a lot of waxing and waning, some push crash cycle. She was trying to take care of her children and trying to be the mom she always wanted to be and imagined herself being. Her dysautonomia we managed that pretty well with her volume, vasoconstriction, heart rate control with medications and water and sodium. We did a lot to try to support her sleep. The mast cell activation syndrome medications made a big difference and definitely helped stabilize her. Unfortunately, about a year later, she really went into a significant crash. She called me about 2 weeks into it, saying that she was nearly bedbound. She had been trying to take care of her children, trying to keep it all going, and it just finally came all crashing down. We spent that first month getting her stabilized, using IV fluids, medications, reducing her nervous system response, and really, really trying to get her to be able to aggressively rest and pace. Even though she was bedbound, there was still room for improved pacing and PEM and rest. We spent a lot of time talking about pacing and PEM, and she really verbalized some newfound understanding of the importance of managing her post-exertional malaise and pacing in order to gain stability of her PEM. Over the last few months, she's gained a lot of stability. She's had a lot of family support. While we aren't back at baseline, she's certainly doing better. So I hope this talk has provided some insight into how we approach ME/CFS care. Our new clinical guide will provide further details for you and other clinical providers, which I hope enhances the knowledge of ME/CFS and how to treat it. Thank you for listening, and I look forward to any questions you might have.
Jennifer, thanks. That was amazing. Such a thoughtful and grounded overview of how we approach multi-system care at BHC. As I mentioned previously, the intention of our presentation today was to focus more on how we approach the care and how to break that down. If you're looking for more specifics on, offering more diagnostic or treatment guidance to your providers, that's really what this clinical care guide is for. But also, we have an entire repository on our website in our Project Echo session, which breaks this down further. So, what you've just heard is not only what we teach, it's truly what we practice. And that clinical approach, our commitment to patient-centered care, is what we've worked to capture and share in our next announcement, which is, with great gratitude and great pride, our clinical care guide, Managing ME/CFS, Long COVID, and Infection-Associated Chronic Conditions. As I mentioned previously, this has been a massive undertaking, built on years of clinical knowledge, medical education, research translation, and most importantly, patient partnership. What makes this guide special is its interdisciplinary approach. It includes contributions from physical therapist, occupational and speech therapist, behavioral health providers, ME/CFS experts, and specialists in pediatric and severe ME/CFS care. It positions the provider not as a solo expert, but as a care coordinator, working collaboratively with patients and across disciplines to deliver informed, flexible, and responsive care. And in the spirit of Dr. Kahn's words, it reminds us to pivot when things evolve or don't go as planned. At its heart, this guide is about returning to the core of medicine, relationships built on trust, humility, and mutual respect. To the team of clinicians, researchers, educators, and lived experience professionals who contributed, thank you. This is only the beginning. We have already started talking about ideas for what needs to grow in a second edition, and we will continue to update as research and our clinical practice evolves. And now I'm honored to welcome Dr. Melanie Hoppers, who has been one of our leading clinician contributors to this project. Dr. Hoppers, I could not have done this without you. You have poured your entire heart and soul into this work. So I'd love to ask you, what do you hope this guide will bring to the field? And how do you see it being used to strengthen medical education and clinical training?
Talia, thank you for letting me speak. And I also just want to say real quick, you said this was a massive undertaking, and that is an understatement. And this wouldn't be here if it weren't for you. So thank you. And, you've inspired me this week with all of your, not just this week, but with all of your hard work. So thank you for that. But as you have said, this toolkit represents more than just a collection of clinical resources. It embodies a lifetime of knowledge from dedicated clinicians like Dr. Cindy Bateman, who devoted her career to understanding and treating one of medicine's most challenging conditions, ME/CFS. The toolkit for me represents a comprehensive tool where you can find most of what you need. I won't say everything because there's always that one other thing, right? But the majority of how to take care of a person with ME/CFS can be found in this tool. I cannot tell you how important that is. A story I have is when I first started to include patients with ME/CFS in my practice, I had a plan. I was going to start slow, easy, someone with mild ME/CFS with a simple problem. And that's how I was going to start. And I was going to go up from there. And within about a week, ME/CFS laughed at my plan. And I was very overwhelmed. And I remember sitting outside the door, outside at my workstation, and I didn't want to go back in the room because I didn't have an answer and I didn't have a great plan. And I had a lifeline. I phoned a friend, and that friend was Jen Bell. And I don't know if she remembers this or not. She probably doesn't, because I called her. I called at different times. I called Dr. Bateman. I may have called Dr. Yeoman, but I phoned her that day, and she helped me work my way through that patient's care. And I went back in that room and I did something for her. And had she not done that, I may have given up at that point. It's hard to feel overwhelmed, and it's hard to not be able to go back in and say, hey, I know what we need to do. So I understand that feeling. And so this toolkit is to try to help people who are feeling that way, providers who want to care for people with ME/CFS, but aren't sure what approach to take. So this gives you not just the answers, ABC, but also subtleties of the care. Like Jen said earlier, start low, go slow. Don't start a new medicine while a person is in PIM. I'll testify to that one. But it gives you those little tricks and tips that are helpful. People with ME/CFS navigate this complex, debilitating condition. They also face skepticism, whether it's from healthcare systems, from, friends, family, and they should never experience it from a provider, but unfortunately, sometimes they do. They deserve clinicians who are equipped to help them and understand the nuances of their condition and who can offer evidence-based care. And that's what this toolkit is for. It's to help our people with ME/CFS. Additionally, we offer this toolkit to medical boards, medical schools, residency programs, anyone who's trying to educate clinicians. The stark reality is that many physicians receive less, if any, less than an hour, if any, education on ME/CFS during their entire training. This toolkit can help fill in that educational gap until more comprehensive curriculum changes can be implemented. So this toolkit represents our collaborative effort to extend that support to clinicians, whether you're seeing an ME/CFS patient for the first time or the 100th time, whether it's a specialist or primary care provider, whether it's a student or an experienced clinician, this resource is meant to help you. So I hope that everyone listening will download this kit. I hope if you're a patient, download the kit, take it to your provider. Again, this is a resource for really any specialty and any sort of provider. Thank you.
Thank you, Dr. Hoppers. I have to add that although a massive undertaking, it was really fun to make this. And it was even more interesting to watch our clinical care team come together and talk about their approaches. So as we were going through and making these final edits, hearing from Dr. Bateman and her years of experience, hearing Dr. Yelman's take on how he approaches care, and Jennifer Bell, and all of us sitting down and just starting to form this beautiful guide that took in everyone's experience and really channeled it into a product. To our other panelists, Dr. Bateman, Jennifer Bliss, Jennifer Bell, do you want to add anything about this product itself?
I'd be happy to comment. I am so proud of our team for coming together and having the vision to create a product like this. It takes some vision and a lot of work. One of the questions was, how do we change things for access to medical care? And that is so incredibly challenging. I mean, I've been working on that my whole career, right? How do I convince the rest of the medical profession, other doctors, other clinicians to change the way they think and operate outside the box? And how do we get our medical education into the official channels, right? But as a nonprofit and a center of excellence nonprofit, we've taken the initiative to say what needs to be said, right? To put out high quality information, put it out there in a big way and send it so that people who need it can access it. We've been doing that, and now we have this product that is going to become a tool to help many, many providers who want to help but don't know how to start because they don't have the resources. So I hope this is just the beginning. We welcome input. We want to continue to make it even better, but it's really amazing. And I think it's as all education, it comes both ways. We give things to patients so they can be empowered and then talk to their providers. And we tried to provide things to medical providers so they can be ready to take that communication and run with it. So I'm really proud and happy of our team for coming and doing this. And thank you so much. And we will move forward from here. And I hope it's well received and very, very effective.
Thank you, Dr. Bateman. I know we have very high hopes and a very determined team to get this into state medical boards on, medical exam, licensing exams, into med schools. So this really is also a call to action to our community to help us in doing that. I think it's been really profound to see just how much of this clinical expertise from those, and I want to just acknowledge that those who have come before us, those of us who are newer to this field, right? And how you all have really paved the way for us. And then I want to also acknowledge, Suzanne Vernon and our researchers who are out there who are helping to validate what we do clinically at BHC. So, and every day our patients are teaching us, right? They are our teachers. So any final comments from anyone before we wrap up today's session?
I know that you've heard a lot from me today, but I'll add one more thing. 4 years ago, I didn't know really anything about this illness. I knew it existed, as I said, and I did believe that it did exist. So I wasn't one of those people, one of those clinicians who didn't think it was real. But this clinician guide, had I had something like that, still working in primary care, really does give you a roadmap to something that's very, very complicated. And so I remember what it was like to not understand. And Melanie, you got me after I had learned something so I could actually help you. But that, it is doable. You can learn how to do this, and you can take care of these patients. So clinicians who are listening, don't shy away, step up. We desperately need more clinicians out there taking care of these folks.
Agreed. Thank you. Dr. Bateman.
I just want to add to that. I want to challenge any clinicians out there. The way you learn about this illness is to take care of a patient, right? To dive in, to spend the time with that patient, communicate back and forth, learn from their experience, learn about what's happening to them, learn how they respond to the interventions, and create an environment that is mutually educational and mutually let's say, satisfying, right? And I stayed in this field because it was so rewarding to me to be able to help people who otherwise couldn't get help. So I challenge clinicians and say, if you are burned out or tired of medicine, one of the best ways to get that back really is to help people who really need your help. So we hope this guide puts it on a level that's understandable to primary care, all clinicians, so that you can dig in and start to help and start to learn.
So well said. Thank you. I'm going to wrap today's session. So thank you all of our panelists, our team, and all of you who joined today. This guide would not exist without the generosity, time, and insight of so many. To the Open Medicine Foundation, our donors, and our colleagues across disciplines, thank you for making this possible. We hope you'll share the clinical care guide widely across your networks, institutions, support communities, and professional circles. You'll receive a follow-up email with a link to download today's clinical care guide, as well as suggested language for sharing if you'd like to post it on social media. As we close, I want to return to the spirit of ME/CFS Awareness Month. This guide and Jennifer's presentation today are more than a resource. It's a reflection of people, of the patients who have carried this knowledge in their bodies for a long time until the field caught up. Thank you for being a part of this community. Take good care, and please be kind to yourselves.